Jim Lynch. I'm a colonel on active duty in the Army. I'm a family and sports med physician, and somehow a family and sports med doc got involved about 10 years ago in doing procedures for PTSD. And for about the next 35, maybe 40 minutes or so, I hope to share my experiences with you and then allow for some time for questions at the end. I am at Fort Bragg, and most of the information I'm going to present from right now here is it comes from out of the military primarily. There's been some work done on Stellate Ganglion Block outside of the military, but really a good bulk of the work's been done in active duty circles, and a good chunk of that in terms of impactful stuff's been done within special operations. So it's an honor for me to get a chance to come talk today in this forum. So without further ado, let me throw these slides up here. Okay, anybody not see slides? Should be cover slide up there, says Stellate Ganglion Block.
I think we're good, sir.
Okay, so again, there's my information down there. I have about 30 slides. I'm planning for about a minute per slide. I'd ask you to hold questions to the end, but we should have plenty of time to ask questions. So if you want to jot them down, that's fine. Again, this is my story from my experiences, and a lot of experiences from folks that you all know and folks that you've probably worked with. Obligatory disclaimer statement. Nothing that I'll provide here is official DoD policy or U.S. government policy. This is the agenda that I'm going to follow. So a brief history of Stellate Ganglion Block and PTSD. It's brief because it's only been around for about 10 years. So since about 2010 till now is really when it's in earnest been a thing. Or been an issue. So I'll give a little bit of backstory on how that came about, because I think that's pretty interesting. You don't really get that from reading the journal articles or stories. I'll hone in a little bit on the underlying brain circuitry malfunction in PTSD, which is pretty darn amazing. And what little we do know, I'll highlight that. But there's an awful lot still that we don't know. I'll talk a little bit about our approaches in trying to integrate brain science with technology, and then really to use neuroscience to guide and inform our treatment in treating PTSD from how it's been done kind of traditionally in the past. The goal is really to challenge you all. I would say you all as both providers as well as potential patients or friends of potential patients, or just folks in the community who see an awful lot of post-traumatic stress that's with or without a formal diagnosis. So I think my goal today is it's really just to kind of educate the group, throw some food out there for discussion, and really spark a challenge in all of you the next time this comes up, to kind of raise that question of whoever's involved in the care of that person, whether it's you, one of your teammates, friend, family member, whatever. Okay, I'm going to make the assumption that all of us on this call right now at least have heard of PTSD, post-traumatic stress disorder. And if you can't recite exactly what it is off the top of your head, that's fine. I think that most people have a general idea of where to find that. The criteria are in the DSM-5, which is the latest version of diagnostic and statistical method that the American Psychiatry Association and really worldwide uses for standard and psychiatric diagnoses. So the DSM-5 describes PTSD as just what you can see up on your screen. It's a condition. It is still considered a disorder. That's kind of a topic for another day. Some people don't like that term disorder, but until that's changed, that's really what I'm referring to this as well. It's a condition that comes from a threat of death or significant injury, or sexual violence to yourself. The disturbance lasts greater than a month, which differentiates that from kind of a normal stress response for many of y'all who experienced combat and may have been put in a threat of death. There's a normal response, and then an abnormal response is something that goes longer than a month, and then it really impacts on the ability of a person to get along with their day-to-day life. The four categories that PTSD kind of divvies things up to in bins are intrusion, avoidance, negative alterations in cognition and mood, and arousal. Arousal is going to be the one that we're going to spend a lot of time on today, but just to point it out that PTSD has all these factors involved. So this, I think, when I first stumbled across this one, it blew my mind. So I would love to point this out to you. When the DSM-5 was created back in 2013, and it took us from the DSM-4 to a new criteria for PTSD, it took a lot of criticism for trying to be all things for all people. The thing that matters on this is if you look on the chart in front of you, in the far columns of DSM-5 and top block up there, the post-traumatic stress disorder, the number of possible combinations, if you go into the DSM-5, number of possible combinations that can lead you to a diagnosis of PTSD is 636,000, which should blow your mind. That's pretty amazing. But equally important, or just as important, is if you look 2 lines below that, the number of excluded presentations is over 100,000. What this means is that there are 100,000 plus combinations of symptoms of PTSD where you can meet one of all the criteria but fall short of the official diagnosis. So there's 107, almost 108,000 combinations of that where you have symptoms in all 4 bins, but you do not meet the full diagnostic criteria. You can look below that for just some comparisons for what's criterion like MDD, major depression. Look at OCD. I mean, the combinations are nothing, single digits. There's a couple of implications for this. One is in the research for PTSD, it makes it extremely difficult to try to find techniques that work, to try to find consensus, to try to get after such a heterogeneous condition as this and distill it down into what works for whom. And especially if you're in the position that I'm in, where I have to look at the person sitting across from me in the clinic room and figure out, okay, what treatment works for this person that has one of 636,000 possible combinations. It gets to be really tricky. I think that's a critical thing. So if you want to ask questions, we can come back to that later, but I'm going to elaborate on that. This is how my patients have presented. So over the past 10 plus years of kind of honing in on what I can do for patients in our community with post-traumatic stress disorder, post-traumatic stress symptoms that may not meet that diagnosis. Really, the biggies that people come to me that actually disclose these symptoms is really poor sleep, poor concentration, poor memory, and then irritable or angry. And a lot of times the irritability or anger may come at home, but it hasn't bled into work yet. It may be snapping at kids or spouse. Sometimes it's snapping at teammates, but usually those are the things that come up. And then there's some question like, hey, doc, what can I do about this, about my sleep and stuff like that? Rarely do people come in and say, I think I have PTSD, and rarely, whether it's happening or not, rarely do my patients disclose like traditional frank nightmares or intrusion things like we think about intrusion symptoms in traditional PTSD. Sometimes there's an issue of coming in with self-medication with alcohol. That's more prevalent than I would like to see, but that's a common thing. And then this kind of loss of patience or irritability, like something's clearly wrong. I didn't always used to be like this. That's how I have seen patients. Not everyone, but that's a really common thread. So we look at PTSD and try to understand this big black box that's our brain, and it's complicated, right? It's all of us who have studied neuroanatomy and are trying to figure out all the things in the brain, all the different regions of the brain and the circuitry in the brain do. It's still extremely confusing. So what we've known for a long time is that there's some areas in the brain that regulate the autonomic nervous system. So again, just to brush everybody up on it, autonomic nervous system is a combination between the sympathetic and the parasympathetic nervous system, which is really a completely different neural network that runs in the body that governs our fight or flight and our relaxation responses. in the brain, somewhere there's a central mechanism to regulate the sympathetic and parasympathetic responses. For hundreds of years, we've had an idea of what structures in the brain probably contribute to this. And really, on this diagram below, you can see the amygdala and hypothalamus are really kind of areas we've keyed in on that have something to do with central autonomic regulation. So that's kind of the approach. That was the approach that I learned in med school. That was the approach that we have kind of latched onto. There's certainly more detail to that, but on the next slide, what I'm showing you here is the kind of the next level of detail that's percolated up over about the past 8 or 10 years. So this is something that I have found fascinating, which is really within the brain, within the central autonomic network. There's really 3 sub-networks that we call the salience network, the central executive network, and the default mode network. The default mode network is kind of the autopilot, the autonomic nervous system going on in the brain. Central executive network is kind of the higher cognitive processing part of the autonomic nervous system. And then there's this thing called the salience network. And these are located in specific regions of the brain. All 3 subnetworks are in different regions of the brain, and there's interconnections between them. So on the slide here, you see them. The interconnections are schematically drawn as like the 2-headed black arrow line, which is just, it's an awesome kind of oversimplification of how this works, because I don't think we fully grasp it. But we know that there's an interplay between 3 subnetworks in the brain, where a dysfunction in one kind of throws off things in the other, so that an overstimulation in the salience network, which has to do with threat response, heightened threat detection, that kind of thing that we see with PTSD, kind of messes up the balance between the central executive network and the default mode network. And it's fascinating to dig into this a little bit more. I can give you all some references if you're interested, because it is pretty interesting. So back to the black thin lines, double-headed arrows, we know that there's some combination of circuitry in between these, but how that works exactly is really, it's going to take a while to figure that out. What we do know, though, is that there are these specific regions in the brain that I already mentioned that we've known about for years, like the amygdala and the hippocampus, that we can feel very comfortable with, are primarily used in the regulation of post-traumatic stress symptoms because they light up on functional MRI. So functional MRI is really, it's just a regular MRI screen with a subject, person, or a patient in the scanner being given a task to stimulate the areas in the brain that are affected. So through many, many functional MRI studies of people with PTSD going through functional tasks with that, we're able to kind of key in on these 4 to 5 areas in the brain: the amygdala, the hippocampus, the ventral medial prefrontal cortex, and the dorsal anterior cingulate cortex. And this is important for a couple different reasons. This also corresponds with this slide I showed you here previously with the different areas in the brain, how the networks connect. But it also gives us a really good sense of specificity in terms of the target areas in the brain using, good technology, modern technology. So then fast forward all the way back to 1954, and there's an awesome book written by Daniel Moore in 1954 called Stellate Ganglion Block. I love it, sitting on my bookshelf right now because I'm a nerd. But it's fascinating in that the Stellate Ganglion Block procedure has been around for 100 years. But this book was written, and this line in it really caught my attention, where the author describes the cervical sympathetic trunk that runs along the neck as an anatomic funnel through which all sympathetic fibers must flow on their way to the head, neck, and thorax. And that's what it is. So my point in bringing this up is that while it's still a mystery exactly how the connections within the subnetworks work in the brain, they all got to go through the highway down the neck to the cervical sympathetic trunk. So that provides us with a really precise target where we can intervene. We may not be able to go deep into the brain in any precise method, although certainly in broad methods, we can do that with things like medications like SSRIs. But in terms of really precise anatomic targets, where we can look is in the neck. So the fascinating thing about this book are all these plates where there were cadaveric dissections of the cervical sympathetic trunk. And what Moore and his colleagues did were able to dissect out all these cadavers. I just put 5 samples in here, but there's probably like 20 in the trunk that describe, I'm sorry, in the book that describe all the anatomic variations. And you can see cursor, correct?
Yes, we can see it.
Okay, so cursor's hovering around the number 5 on that diagram right there, which is the right stellate ganglion on this diagram. This is there's not going to be a quiz later. The important thing here is if you look at the diagrams, you really got to squint to see these little ones here. But the intent or the purpose of me showing the slide is that there are really all these different anatomic variations, and sometimes we forget that in medicine, and we look at one anatomy book like Netter or something, and we think that that's what everybody looks like. That's not true, and it becomes really important when you're sticking a needle in someone's neck to appreciate anatomic variations, and then how that can impact things. So really, I just think really there's some really elegant work that was done in the 50s. There's a fantastic paper came out of New Zealand in the 20s that 1920s that describes this, and it's been a fun journey for me to kind of go back and dig through this stuff on one side while looking at 2020 functional MRI data on the other side. Okay, so I've already said stellate ganglion block's been around for 100 years. It's not new. It's actually ridiculously safe, considered it was done blind or clinically guided for the first 80 years, meaning palpate with the fingers down to the bone, stick a needle right in between your fingers without using any kind of imaging at all. And that has fantastic safety data. We don't do that anymore because we have the benefit of fluoroscopy or ultrasound. So you can imagine the safety is significantly better. Stellate ganglion block has been used to treat sympathetically mediated pain syndromes. So nowadays, if you ask a pain doctor in the hospital, what do they use stellate ganglion block to treat? They'll talk to you about any sympathetically mediated pain thing. The most common would be CRIPS. So what was previously known as reflex sympathetic dystrophy is now known as chronic regional pain syndrome, where the sympathetic nervous system has been disturbed for whatever reason, whatever insult. We don't really know why, and then becomes hyperactivated. And an SGB can be really helpful to treat CRIPS of the upper extremity, whether it's right shoulder, right arm, hand pain. Shingles it can be used for. The people that have particularly painful post-herpetic neuralgia is very helpful. And then anybody with upper extremity amputations that suffer from phantom limb pain, it can be also quite helpful. What the SGB does is it resets the autonomic nervous system, which is, if you use slang terminology like resets, people will challenge you on that. I wish I could tell exactly what's happening in terms of the resetting of a nerve, but what we know from pain medicine and what we know from injecting nerves is that there's some kind of resetting or rebooting process that happens with the nerve block. Why? I don't know. Maybe somebody knows, but there is a sense of a rebooting process. The fact that can happen with a peripheral nerve, a sensory nerve, is well known. So the fact that could happen to a sympathetic nerve or an autonomic nerve just makes sense. And we kind of stumbled our way into this. But this is how stellate ganglion block has been used. And really up until about 2010, the idea of using it for PTSD was not considered. In the book that Daniel Moore published back in '54, it's got indications in there from everything from angina to asthma. It's really fascinating because there's actually articles coming out now about using SGB to treat heart conditions as well. So it's an interesting thing. So I mentioned before that the amygdala and the hippocampus are kind of two key players, two key regions in the brain for PTSD symptoms. So the reason the stellate ganglion block is so appealing is that the stellate ganglion has direct connections to the amygdala and the hippocampus. Where we don't know all the connections from the cervical sympathetic chain, where they all go, you would think that in this day and age we would know that, but we really don't. And it's actually fascinating how we're peeling back the onion to try to figure this out. But we do know that in this diagram here, in this just cartoon schematic, what you can see down here is the stellate ganglion, which is usually at about the C7 level. Right up here at the top is the superior cervical ganglion, which also runs along this, cervical sympathetic trunk. So there's stellate ganglion, middle cervical ganglion, superior cervical ganglion. The pictures that I showed before from Daniel Moore's book show all kinds of anatomic variation, that some people don't have a middle cervical, some people it's joined up with the stellate, others it's a little higher level. The important thing is that when we refer to a thing called the stellate ganglion block, we're really talking about a block of the cervical sympathetic trunk in the region of, in the region of the stellate and middle cervical ganglion. Although what we don't know is where all these small connections come off the cervical trunk go, where they travel both distally down the body as well as where they connect in the brain. I think there's a lot more to learn on that. But what we do know right now, and what is attributed to why this works so well, is that there are connections to the amygdala and the hippocampus. So having said that already, all these targets in the brain are hard to get at, but we do know the cervical sympathetic trunk travels right along the neck, and it's pretty easy to get to. So what you have here is, this is a transverse section. So it's a short axis view of the neck, right side of the neck. And I'm not going to try to explain all the structures in here, but I'm just going to point out. So to orient you, the left side of the screen over here would be midline of the body. And this structure, for those of y'all who know ultrasound, which I know there's quite a few on here, this is a bony projection. This is called Chasniak's tubercle of the C6 vertebrae. This is kind of the bony landmark. And this muscle, which is a poorly defined black structure that looks like muscle in a better view, is the muscle called the longus colli. The cervical sympathetic chain runs along the fascia of this muscle called the longus colli. You can't see the cervical sympathetic trunk on this picture, and it's very difficult to see on ultrasound, but we know where the target is. We know that it's right in here. Just to orient you again, this is internal jugular. This is common carotid. So there's these two giant vascular structures, as well as some smaller ones that live in this area. But the trajectory of the needle is to come from lateral to medial, and to hit the target right about where the tip of the needle is. Like I said, it's not a complex procedure. It's simple in that what you have to do is quite easy. It just is very, it takes skilled hands to do it, and it's not the kind of thing you want someone who has minimal experience with ultrasound guided injections to just tackle right away. This is really what the procedure looks like in terms of the room. It's done in a regular procedure room. There's a crash cart available. You need to be able to handle whatever medical emergencies go on. And then other than that, it's patients lying awake on their back with ultrasound available, and pretty straightforward, as opposed to many other procedures that require OR settings, anesthesia, and whatnot. The stellate ganglion block blocks the fight or flight system temporarily. We use ropivacaine. Some people use bupivacaine. Either way, it's a long-acting anesthesia. So the effects of the stellate ganglion block only last as long as the anesthesia, and then they wear off. What remains behind are some of these long-term psychological effects, but the physical effects that we see wear off in just 6 to 8 hours. So in the picture down here, you see a Horner syndrome. This is a patient who's blocked on the right side. So the findings that you see in Horner syndrome are on the right side, and it's meiosis, ptosis, anhydrosis. So that's lack of sweating, which you can't really see in this picture. But you see a injected sclera, pinpoint pupil, droopy lid. What you can't see, but the patient can feel, is a congested nose on the right side. This is confirmation that the block was done in the right place. And this can show up as soon as 30 seconds to a minute or two after the block is done, right there in the procedure room. So you have instant confirmation. Not to mention the fact that you're watching where your needle tip is when you do the procedure. But all this does is kind of confirm that. There's a couple of things that can happen afterwards that are uncomfortable but not serious. And that's the sensation of something in the side of your throat, you know, we call globus, like something that's kind of a little catch when you swallow that wears off in a few hours. And then occasionally you can block the recurrent laryngeal nerve, again, temporarily for a few hours, but it's annoying if it does happen to about 5% of the people that I do that get kind of a raspy helium voice for a few hours, and it is annoying. Those things are reversible. The things that we worry about are the serious things. So the most serious thing would obviously be death that would be caused most likely from an intravascular injection, which again, I think goes to the point of why we use ultrasound guidance. Every time I do the procedure, we go through excruciating detail with power flow Doppler on to look for all the anatomic variations in vascular structures. And I find them. I'll see a vertebral artery every now and then, not where it's supposed to be, but right in the path of the needle. My reason for bringing this up is there are still, there are doctors who are experienced that have been doing SGBs for a long time under fluoroscopic guidance. And amazingly, they don't have that many adverse events. It just blows me away why you would want to do that with the inability to see vessels with fluoroscopy. Whereas under ultrasound, you can see the anatomy, awesome, fantastic, and see all the structures you want to avoid. So most people that I know that are pain trained in both fluoroscopy and ultrasound have all switched over to doing ultrasound guided stellate ganglion blocks, and very few still do fluoroscopy. The concerns again then would be intravascular injection, which I just, on that tangent, was just to point out that would be a really hard thing to do. We're really, really careful about that. But that would be significant and cause a seizure, and a seizure that's not able to be treated could be significant. I do see an occasional vasovagal response, but the good thing is patients are laying supine anyway, and they usually respond really well to just a little bit of stimulation. And again, they're wide awake during this, so it's usually extremely safe. Okay. A little bit of brief history here. I feel like I'm running a little long-winded, more long-winded than I want to be. I have a tendency to do that, so I apologize. But let me at least tell a brief story here. I mentioned before that this is really in the past 10 years that something's gone on. So just some highlights here. In 1990, a doc from New York City named Leibovitz published the first paper on this, a 15-year-old girl who was a gunshot victim who had crypts of her right arm. So she had reflex sympathetic dystrophy, and they gave her stellate ganglion blocks to treat that. Well, it turned out it also treated her PTSD really well, and they were surprised, so they wrote it up in 1990. No one ever read it and got forgotten about. And then in 2008, a doctor in Chicago named Eugene Lipov found the same thing with his patients. He was treating somebody for upper extremity pain who happened to have PTSD as well, noticed that their symptoms got better. He wrote that up. So in 2010, an Army doctor by the name of Sean Mulvaney, that some of you all may know, he's an Army doctor, but he's also a SEAL, which he'd be sure to tell you that right away if you met him. So I'll just mention it now. Sean Mulvaney really ought to be credited with bringing this to the military. So between he and Brian McLean, who's also another Army doctor who works out in Tripler, who's done over 1,000 SGPs, really experienced. Those two guys in 2010 were looking for a better way to treat their patients. And I give Sean Mulvaney all the credit of being the guy that really broke this open and brought it into the military community. And within the soft community, we were able to kind of explore it at that time before, I guess, going mainstream, for lack of a better term. So I'll show you a couple of studies on that. That was in 2010. Fast forward to just this year, and a large multi-center randomized control trial took place in over the past 5 years at Tripler in Hawaii, Landstuhl in Germany, and Womack at Fort Bragg. The results were done a couple of years ago, and the study was finally published online last year. But that was kind of a watershed event in terms of reaching the evidence that we needed. So I'm gonna cruise through some of these. We can come back on questions if you want. Okay, after Sean Mulvaney, Dr. Mulvaney introduced this procedure to me, he taught me how to do it. Both of us are sports medicine, ultrasound trained, registered musculoskeletal ultrasound, legitimate certified people. So it wasn't like a party trick or something. He introduced that, and the two of us did quite a few within the soft community and published our results in this case series of 166 patients back in 2014. The punchline, if you can't read the small print, is that 70% of the patients got better immediately and then persisted for about 3 to 6 months. In comparison, if you look at the best treatments for PTSD in the clinical practice guideline, the best, if you're really optimistic and you read through rose-colored glasses, you'll see that the best treatments for PTSD range somewhere around the 30% success rate. So this was kind of a big deal to us. This was what the study was. It was basically all people from the special operations community, all active duty military members. You can see the demographics there on the slide. All had deployment experience. Many had a lot of deployment experience, and the results were pretty amazing. As you all know, case series no one cares about. It got published. No one cares. It's not randomized controlled trial, so it just kind of sat there. This is a graph of what the responses look like. In dark blue, responders are defined as somebody who scores greater than 10 points of improvement on the scale that we use is called the PCLM, or PTSD checklist military. So I think I skipped over that there. Yeah, so where it says PCLM over 35, this is a PCLM is a 17 question questionnaire that asks about post-traumatic stress symptoms. The PCLM has been replaced by a PCL5, which is now a 20-question questionnaire, but the concept remains the same. A 10-point change in a PCL, whether that's a PCLM or a PCL5, is considered the minimal clinically important difference. So that's a big deal to drop 10 points on a PCL. And what we found here was the responders, the people that dropped more than 10 points, were like 80% of our patients. So again, that's pretty amazing, but it's not really good science to the larger medical community because it's just a case series. The question that we got asked within our community is, hey, doc, you said that this thing's going to affect my fight or flight system. That sounds pretty dumb because I've just spent the past 15, 10, 20 years trying to hone my fight or flight system. The last thing I need to do is have that thing shut off right before I deploy. So in an attempt to answer this question, we did a study looking at some neurocognitive measures that was published in 2015. And it was really to answer the question because we actually didn't know. We thought, I don't know, people seem to anecdotally report that they're doing fine and they're not crying at movies and things like that. So, hey, let's see what happens. So we use the tool that measures, sorry about the busy graph and the small fonts, but I'll explain. We used a tool that would measure a variety of neurocognitive impulses, from dynamic visual tracking, speed, reaction time. It's actually a lot like an ANAM or an impact test for anybody that's done TBI testing or concussion testing. So to point out, the blue bars are so baseline, before a stellate ganglion block, and the green bars are afterwards. And all we really cared about was, do they stay about the same? Fair enough. Like, as long as we're not causing a big detriment in somebody's visual tracking speed, then we're okay with that. But we were kind of shocked to find out that in 3 years, actually, people got really good, got really a lot better. While not a lot has been done with this information since 5 years ago when we published this, I think it's pretty amazing that not only could we feel comfortable telling people that stellate ganglion block is not harmful in terms of neurocognitive effects, there may actually be a little bit of a performance benefit. We have not done much to track the length of that or any more details on that, but I at least feel really comfortable telling people in our community, don't worry, don't be concerned about a detriment in your performance based on this study. Okay, in terms of the 636,000 combinations of symptoms, what I thought would be really helpful is if somebody asked me, yeah, doc, but what does this really help with? What symptoms? So what we did is took the PCLM 17 items and we just ranked out. If you look at the numbers at the bottom of the graph there, those are each of the 17 numbers to look at which were the items that improved the most following a stellate ganglion block. And if you'll see down there, it's really the bottom third of the sheet. So the bottom sheet, the bottom third of the PCLM has a lot to do with hyperarousal. But questions 14, 15, and 13 are really the ones that jump out. And those are irritability and angry outbursts, difficulty concentrating, and difficulty with sleep. So back to the point where I said, these are how my patients present to me. These are the things that were most impacted that we studied following a stellate ganglion block. This is another way to portray the same thing. So down at the bottom of that graph, you got to see, it's not easy to read, but jammed in there are, in order, the 17 items on a PCL. And if you'll see on this first slide here on the left, this was baseline. Then we followed patients 1 week out, and then 2 to 4 months out to see. So you get kind of an overall feeling that green is good, red is bad, and people start out pretty messed up. And down here at the bottom half of that, with all these hyperarousal symptoms, people start out pretty bad, and over time did pretty well. So this heat map is just another way to portray that graphically. I would encourage all y'all, if you want to know more about this, this was something that Dr. Mulvaney and Dr. Cotwell, Russ Cotwell, former Ranger Regimental Doc, and I published, and we published it in the JSOM, knowing that the intended audience was us, right? So us, me, you guys would be the ones to read this, and any other providers that are interested in answering questions. So, and I'm happy to share this. I think I can push a PDF out on this after the fact, but it's a nice overview that we published a few years ago. Okay, shortly after that, the group out in San Diego decided to run the first randomized controlled trial of SGB. And the punchline is it was a negative study. So they used a small study, 27 blocks compared to 15 shams. The sham, they injected saline in the same area as you would inject ropivacaine, so right along the cervical sympathetic trunk. And both groups improved, but there was no difference between the two. So this was a big deal because it was kind of a punch in the gut for those of us that were enthusiastic about this. But if you dig into the study a little bit more, quite a few of the people had secondary gains to not get better. Like we're all familiar with in the military, that there are folks undergoing med boards and things like that that had a reason not to get better that kind of confounded these results. Either way, it got hold in the community, and there were quite a few people that just said, despite all this previous evidence with SGB, that we finally have a level 1 study, a randomized control trial that shows that it's no better than sham, and we're going to just drop it. We're not interested anymore, which was discouraging until this year. I was involved. I put in bold font on this list the SOCOM providers that were involved in this. So between Sean Mulvaney and myself, Sean Kane, who was a former USASOC physician, sports med type like me, as well as Eugene Kim, who's the former USASOC psychiatrist. But this study went on for almost 5 years, finally got published last year. And here's the results. Oh, I'm sorry again. So this was, yeah, here's the results. So this is with N of 113, so a much larger study, multi-site, with twice the effect on the stellate ganglion block arm as on the sham arm. So this is using the gold standard tool, which is called the CAPS, or clinician administered PTSD scale, where the same number is important, but greater than 10 is considered a clinically significant improvement. In this study, the SGB group had an improvement of 12, so greater than 10, and the sham group had half that. So this was a huge deal to us. It got picked up in JAMA Psych, which is the #1 psychiatric journal to be published. I was doing cheetah flips when it came out, thought we would be able to persuade the DOD and the PTSD to add this onto the clinical practice guidelines. But they said, not so fast, Dr. Lynch. We need to see another randomized controlled trial before we'll make up our mind. So that's a little bit of where we stand in terms of the story and where we stand in the where the research is right now. Okay, running long. We have plenty of time for questions, I think. But really, here's the take-home point. PTSD is super heterogeneous, difficult to diagnose, difficult to study, and really hard to treat if you view things as one size fits all. If you look at things in the terms of precision medicine and look to treat symptoms more than treat a diagnosis, I think we'll have much better luck. There's dysfunction in a bunch of different areas that contribute to PTSD. We know that hyperarousal is an independent predictor of poor treatment in PTSD. It's been studied extensively in the psychologic literature. And from what my psychology colleagues tell me, is that folks who get a SGB before not only are, one, less resistant to go seek therapy in the first place, but number two, they can tamp down their physical symptoms to dig right into the psychological things. So it makes therapy better and more efficient. We know that the sympathetic nervous system is involved in PTSD. We've known this for a long time. We're just finally kind of attacking it with a precision medicine approach and trying to target that piece. And then we have tons of evidence now to show that SGB is effective. We only have one randomized trial to support it and one randomized trial to refute it. So in the big world of medical literature, they consider this kind of it's not a done deal yet. But I think if you go back and look at the magnitude of effect on all the other studies, we can say really surely that it has rapid onset that day, provides durable relief of symptoms, which we find roughly to be 3 to 4 to 6 months, as long as people are continuing to do their therapy. And then, yes, you can get a repeat procedure at that time if it's warranted. Patients like it, it's acceptable, and it's really safe when performed by a physician who's experienced in it. This is really my last slide, and it's something I just want to leave you with. I think the point that we have a lot of people in our community that have been diagnosed with PTSD is fine, but I also think that's just the tip of the iceberg. I think there's a whole ton of people who may not meet full criteria for PTSD under the DSM-5. We already know that's 100,000 possible combinations, but I think that there's a lot of people that could benefit from a treatment of overstimulated sympathetic tone, or what I refer to as dysfunctional sympathetic tone. How that's going to play out in the future in terms of a diagnosis, I'm not so sure, but there's definitely room for this. We know what stellate ganglion block does to treat hyperarousal symptoms, and it can be really helpful as an adjunct to therapy. So I think there's more to follow on this, but I think there's a giant bottom of that iceberg that could potentially benefit. This is not touted to be a standalone magic bullet treatment. It always should be done in conjunction with therapy. So as a shout out to one of the first psychologists that helped us with this, on the left side of that picture is Dr. Shumi Rollins, who works in our community, who was quite helpful in giving us the psychology perspective to this. And every patient I do an SGB on sees a psychologist or social worker both before and after the block. And I see that as an integral part of this treatment. It's not something that should be divorced or uncoupled from psychiatric care. That is it. As they say in my family, if it's stupid and it works, it's not stupid.